Hello Insta family, it is Dr. Tamara Hunter here and of course I am doing this right in the middle of crazy time. The dog's barking, the child's just finished dinner and heading off to dance, but we women, we can multitask. So here I am to do a happy Valentine's Day live for all of you guys. So I've had a few direct messages sent through. Hello, Sandy. Good to see you. Chantel, Alicia, it's Sashi. Lovely to see you guys on here. I've had a couple of direct messages, but if you have a question, please don't hesitate to drop it into the comments section. You know the rules and guidelines on asking questions, but I have had a couple of direct messages for some questions. My pleasure. Yes, happy Valentine's Day, guys. Sending you the love. So, first question that was asked was if I have been shown to have blocked tubes when doing a tubal flush, that might have been an HSG or an Hysteroscopy or even a direct vision on laparoscopy. Should we do something about that if I have recurrent implantation failure? Fantastic question. And my answer is, well, yes, I think you should. So the first thing is understand that there is a certain false positive rate that happens with diagnostic testing such as an Hysteroscopy or an HSG, meaning that there are little valves in the tubes, and if you flush too hard, they can actually kind of close and the tubes can appear to be blocked when they're not actually blocked. So that's the first thing. I would always go back to the practitioner who performed the procedure and say, hey, could this potentially be a false positive? But in reality, if you are doing IVF for another reason, you actually don't need your tubes. And if you do have blocked tubes, it could be that the process that caused them to be blocked, so endometriosis or adhesions, has actually blocked them and led to an accumulation of inflammatory fluid. Now, this could have the appearance of a hydrosalpinx, so a swollen tube on an ultrasound, but it might also not be evident on ultrasound. And that inflammatory fluid could be refluxing back into the cavity of the uterus, creating a really hostile environment to put an embryo into. So, would I suggest management of that? Probably with a salpingectomy, taking out the tube. I would definitely have a chat with your fertility doctor about that, because obviously if you take out both tubes, then there's absolutely no way you're going to conceive naturally without any tubes. So definitely have a discussion about the pros and cons of salpingectomy. But we know in the context of a hydrosalpinx, that will improve implantation failure. So that was a really good question. Oh, since that one was asked, I've had a bucket load more dumped here. So let me have a look. Chantel Dua, I was hoping to say hi the other day when we visited Dr. Cylinder, but we didn't see you. So we'll say hi here. Thanks for reaching out. Good to see you. Dr. Cylinder's great. Santinus Treasures, what are your experiences on treating men with gonal F and Ovidrel for the improvement of sperm quality, morphology, and DNA fragmentation? Okay. If you have a low testosterone environment on serum, okay, let me rephrase this. If you take a blood test off a man and you assess his testosterone level, you can expect that the testosterone concentration in the testis is about 100-fold higher. So we need a really testosterone-rich environment in order to produce sperm. So testosterone is really important. There is a diurnal over a day variation in testosterone levels, and the best time to do a serum testosterone measurement is at 8 a.m. in the morning. Now, if the testosterone is within the normal male range, then we can happily assume that the testosterone level in the testis is fine to help with DNA fragmentation, to help with sperm production and sperm quality. If the testosterone level is low, then you can consider maybe improving that by giving Ovidrel in replacing the LH, because it's the LH that stimulates testosterone production. The FSH is only useful, and that's the gonal F, it's only useful if you have hypospermatogenesis or low sperm count. It's not really useful to improve sperm quality. So Ovidrel, definitely in the context of a low testosterone environment and perhaps high evidence of DNA fragmentation. Testosterone doesn't really change morphology, so I don't think that would be the indication to utilise Ovidrel. So I'm hoping that is helpful. I think I answered that in a very convoluted way. Sashwa, good to see you back on here. Hi, Dr. T. An age-old question. Your thoughts on fresh versus frozen for an early 40s? I like the play on words there. Pregnancy rates are no different between fresh and frozen transfer. However, and that is somewhat dependent on the clinic that you're going to. So I would always ask the question, what are your fresh rates like? What are your frozen rates like? I think it's a fair question. Early 40s, what would you do? Well, the recent data, and I did do a little reel on this, feel free to go back and check it out, but the data suggests the value of the corpus luteum, particularly in an older population, to reduce the chances of you developing hypertensive disease in pregnancy, preeclampsia, which can lead to growth restriction, preterm birth, and so on. So I think the practice of moving towards low-dose stimulation, natural cycle, modified natural cycle, is the way to go to have the presence of the corpus luteum to improve pregnancy outcomes. There is some data, certainly in our clinic, that low-dose stimulation, see you later, is going to actually improve pregnancy rates. I don't think that's across all clinics, but certainly the late pregnancy complications are improved by having that corpus luteum present. Hopefully that answers your question. Are there any more that have been dropped in here? Christianettes, what can be done to improve embryo development in those with a balanced translocation? Ooh. I think that it is not so much about improving embryo development, but rather ensuring that you are transferring a chromosomally normal embryo. So it depends on the size of the translocation as to, because we all talk about this sort of 25% chance, or 25% of the embryos created will have the unbalanced version, 50% will be carriers, and 25% will be normal. In reality, depending on where the translocation is, they're not those textbook cases. And so there are some really nasty translocations where a much higher number of embryos are going to be affected, and that's going to play out in a number of the embryos falling over at cleavage stage, and it appears poor embryo quality. But it's not something that can be treated prior to the development of the embryos. It's a matter of doing enough cycles to eventually find that chromosomally normal embryo. So it might be that you have to go through dozens and dozens of embryos to find that chromosomally normal one. So that's a really difficult question to generically answer, but that's probably the best answer I can give you. Melissa, hi Dr. T, what are your thoughts on Zoladex the month before embryo transfer in patients with endometriosis? I don't think it's of any value to you a month before. I think if you have severe endometriosis that might be causing recurrent implantation failure, I think that probably needs to be in play for at least a good 3 months, 90 days. That's what the evidence seems to suggest. There's also some evidence to suggest that you can get away with using a pill in a continuous fashion in that clinical scenario and also improve pregnancy rates. I kind of like Zoladex because I feel that you get that hypoestrogenic state much better with Zoladex than with the pill, but there's been no head-to-head studies, so I don't think we can say for sure which is better. Hello, Alison, cousin, how you doing? Journey to you, my baby. If no precious issues with having a good, I think you might need to ask that question again. If no, gonna have to ask that question again. I can't quite interpret what you have said there. I'll give you some time to retype that out. Journey to you, my baby. There was some other questions that were asked on direct message. Somebody asked me the question, two questions actually. PCOS, severe OHSS, how can I prepare myself for another IVF cycle? Obviously, to not get OHSS. So I would definitely encourage you to be on metformin. We know that that reduces the risk of developing OHSS during an IVF cycle. I think aiming for no more than sort of 8 to 12 eggs collected. We don't need to aim for everything. So having a lower number will reduce your chances of getting OHSS. Doing a freeze-all, so what we call segmentation, so creating the embryos and freezing them, allowing the ovaries to settle down, and then doing a transfer in a modified natural cycle or even in an HRT-FET cycle would be better to reduce the chances of you getting OHSS. That also allows us to use a decapeptyl trigger as opposed to an ovidrel trigger, which just increases your chances of getting OHSS. Using an antagonist cycle, so one where you're using orgalutran rather than Cineral, for example, is the right kind of protocol to be using. So there are lots of things that we can do, and certainly having done a cycle and knowing what sort of cycle leads to OHSS with you, there is value in knowing that information and changing it up the next time. So hopefully that is useful. Thank you, Journey to My Baby. If no precious lining issues pre-embryo transfer, but not pregnant. I think that should say if no previous lining issues, but not pregnant, would a hysteroscopy show you much or give you any really useful look, if you've had, autocorrect, I agree. If you've had one transfer, I don't think I'd take you off track down the pathway of a hysteroscopy unless there was some clinical reason you're getting funny bleeding in the cycle. But certainly if you have had recurrent transfer of seemingly normal embryos, even genetically tested embryos, battery issues. I think that it's very reasonable to go and do a hysteroscopy. You may even consider a laparoscopy at the same time to look for signs of endometriosis. But, chronic endometritis is a hysteroscopic diagnosis, having a look at the lining macroscopically, even taking a sample of it. Sometimes 2 ultrasounds might not pick up polypoid endometrium or polyps that can impact on recurrent implantation failure. But recurrent implantation failure is the transfer of 3 or more seemingly normal or good quality embryos. So that's the point in time where I would probably sort of venture to hysteroscopic review. I hope that answered your question. Do I rate prenatal vitamins? The one prenatal I think is really important is folic acid. That has been proven in large-scale studies decades ago now to reduce the chances of neural tube defect, even if you have a folate replete diet, so lots of green leafies. Taking folic acid does improve outcomes. If you're iron deficient, take iron. If your vitamin D is low, take vitamin D. If you're not having 2 or more omega-filled meals per week, such as a fish like salmon, for example, fatty fish. So if you're not doing those sorts of things, then prenatals are important. As far as all the other nutrients go, don't really see if there's any value in them. All right. Whew. Now, are there any more questions? I did have a couple of other questions on direct message. I'm just trying to rack my brains. I should have written them down. So there was the one about PCOS. There was the one about the tubes. They were really good questions and I can't think of them. If anyone is on here and sent me a direct message with a question, can you dump it into the feed? And okay, Melissa's written another one. Is it recommended for endometriosis patients to complete egg collection before excision surgery? No, not necessarily. If you are doing surgery for endometriomas, so endometriosis on the ovary itself, which is the surgery itself will cause damage to the cortex where the eggs are, I would definitely have that discussion about considering egg freezing or even embryo freezing prior to surgery, particularly in the context where the ovarian reserve may be low, judged on an antral follicle count. But I don't think you necessarily have to do egg collection prior to endosurgery elsewhere in the pelvis. I would think that there is an argument for particularly if you have a really good surgeon who thinks that they can completely resect. I do think that it might be worth, I'm just thinking about what I'm going to say here. I do think that discussion about embryo creation prior to surgery and then down regulation with something like Zoladex is important. I would not really be giving Zoladex prior to doing an egg collection. We find that the response of the ovaries is not as great. So probably the chronology for me would be collect the eggs and freeze them, or create the embryos and freeze them, do the surgery, give the Zoladex to downregulate for 3 months, and then do the embryo transfer. That's the order that I would do things. Sassy Louise has a question. How would you manage? Oh, thank you. That was the other one. How would you manage a patient with a hepatic adenoma during IVF? Look, that's a really great question. So to those who don't know, a hepatic adenoma is a benign tumour in the liver, and adenomas can be quite sensitive to hormones, so particularly estrogen and progesterone. Stable adenomas are not thought to respond, and if you've had normal cycles your entire life and your adenoma's been kind of stable, then it's probably not going to be responsive to an IVF cycle. But I mean, similarly, you would have to be careful during pregnancy because the hormones, estrogen and progesterone, are sky high during pregnancy, and so that would potentially grow the adenoma. So I would absolutely be recruiting the advice of the hepatologist. What do you think about this? And if they felt that there was going to be some impact by the hormones, I'd probably get an MFM consult. You know, how are you going to manage this in pregnancy if this grows? And then if there is still concern, we might give medication like letrozole, for example, to reduce the amount of estrogen produced while stimulating the ovaries. Often use it in breast cancer patients as well. So I think there are a number of steps that have to be put in place, but the big one is to chat to the hepatologist about, is this likely to be responsive to hormones during stimulation? Good question though. Yeah, I did have to think about that one when you posed it. It was a good one. Guys, I've been on here for the better part of 20 minutes. Are there any other really urgent questions? What I would suggest is if I haven't answered your question or you've seen this at another time, don't hesitate to send me a DM. The questions that come through are very thoughtful, and some of them I have to go and have a think about before I jump on and answer them. But other than that, I will see you here next Wednesday. And I've got some great guests lined up for the next month or two. A couple of people have just said, yeah, I'd love to hop on with you. So keep an eye out for some of the patient stories that we'll be sharing soon. Good to see you. Have a happy Valentine's Day.